I'm going to ask just to start, and then whoever can join will join.
Okay. So, good afternoon, team. Good afternoon, everyone. Thank you for listening to our talk today. So today we're talking about neonatal jaundice. By definition, it is the yellow discoloration of the skin and mucous membranes due to hyperbilirubinemia. It is one of the most common conditions that requires medical attention and hospital readmission in newborns. So we've got types of jaundice. We've got the physiological jaundice, which appears on day 2 to 3 of life and peaks on day 3 or 4 in infants and day 4 to 6 in preterm babies. And in physiological jaundice, only the unconjugated bilirubin is increased. And then we also have pathological jaundice, which appears within the first 24 hours of birth. And it can occur at any time after birth. It persists in up to more than 10 days in full-term babies and can persist up to more than 14 days in preterm babies. Here in pathological jaundice, unconjugated and or conjugated bilirubin are increased. And then we have breastfeeding jaundice, which is the unconjugated bilirubin levels, which are high in the first week of life in breastfed babies, though, due to calorie and fluid deprivation and delayed passage of stools. It improves with increased frequency of breastfeeding. So we have red flags for pathological jaundice, which are if onset is in the first 24 hours of life, and if the duration is more than 14 days in term babies and more than 21 days in preterm babies. If the mom is Rh negative or blood group O, or if the baby has anemia, of which in this case you also have to do the hemolysis workup. If the baby is sick, for example, has sepsis, temperature instability, hypoglycemia, acidosis, or hepatosplenomegaly. If the baby has clinical features of bilirubin encephalopathy, the kernicterus. Also, if the serum bilirubin is rising more than 50 micromoles per liter in 6 hours, or if the jaundice is not responding well to phototherapy. Also, one of the red flags for pathological jaundice is if there's history of jaundice in siblings or family has G6PD deficiency. So, moving on to pathophysiology of neonatal jaundice. Neonatal jaundice is a results from simultaneous occurrence of two phenomena. One, when the bilirubin production is elevated because of increased breakdown of fetal erythrocytes. This is the result of the shortened lifespan of fetal erythrocytes and the higher erythrocyte mass in neonates. Two, if the hepatic excretory capacity is low, it could be both because of low concentration of binding protein ligandin in the hepatocytes and because of low activity of glucuronide transferase, the enzyme which is responsible for binding bilirubin to glucuronic acid, thus making bilirubin water soluble. That is the conjugation. So I've got a sketch there of sort of a summary of the pathophysiology. So bilirubin is produced in the endothelial system as the end product of heme catabolism, as we know, and it is formed through oxidation reduction reactions. So In the first step, biliverdin is formed from heme through the action of heme oxygenase, and then water-soluble biliverdin is reduced to bilirubin, which, because of the intramolecular hydrogen bonds, is almost insoluble in water in its most common isomeric form. So because of its hydrophobic nature, unconjugated bilirubin is transported in the plasma, tightly bound to albumin. Binding of bilirubin to albumin increases postnatally with age and is reduced in infants who are ill. The presence of endogenous and exogenous binding competitors, such as certain drugs, also decreases the binding capacity. I mean, the binding affinity of albumin for bilirubin. So a minute fraction of unconjugated bilirubin in serum is not bound to albumin. This free bilirubin is able to cross lipid-containing membranes, including the blood-brain barrier, leading to neurotoxicity. So when it reaches the liver, the bilirubin is transported to liver cells where it binds to ligandin. Uptake into hepatocytes increases with increasing ligandin concentration. So ligandin concentrations are low at birth, but rapidly increase over the first few weeks of life. Ligandin concentration may be increased by the administration of pharmacologic agents such as phenobarbital. Conjugated bilirubin is bound to glucuronic acid in the hepatocyte endoplasmic reticulum in a reaction that is catalyzed by uridine diphosphoglucorenyltransferase, the UDBGD. Oh gosh, this word is long. Now, moving on to causes of neonatal jaundice in the first week. So that's the table. We've got the causes of neonatal jaundice between day 3 and 5, and then day 5 and 7. So in day 3 and 5, if there's blood group incompatibility, if there's bleeding and bruising, physiological infection, that which, for example, if it was intrauterine acquired, immaturity, maternal diabetes, and then the causes in between day 5 and 7. Infections like UTI, gram-negative, sepsis, neonatal hepatitis syndrome, metabolic disturbances, for example, galactosemia, endocrine like hypothyroidism, biliary atresia, and then moving on to history taking now for neonatal jaundice. So it is important to find out the duration. When taking history, you must find out the duration, because neonatal jaundice typically presents on day 2 to 3. And as I've explained earlier, the types, we know that the one that is visible in the first 24 hours of life is not physiological, and further evaluation is requested. So infants with severe jaundice that continues between the first to 2 weeks of life, first to 2 weeks of life, the results of the newborn metabolic genes should be checked for galactosemia and congenital hypothyroidism. It is also important to ask about family history, previous siblings that had jaundice and required treatment, ask about Gilbert syndrome and hemolytic disorders or liver disease in the family. Also, history of pregnancy and delivery, maternal illnesses, viral infections, drug or any herbal intake, and whether there was delayed cord clamping, whether there was birth trauma, and also postnatally, if there was loss of stool color, if the baby is being breastfed or not, and also if the baby is being given any drugs or herbal use. Physical examination. So when doing the physical examination, face and forehead is it's one of the most identification points for the neonatal jaundice. And the identification is by pressure on the skin, since blanching reveals the underlying color. Gradually becomes visible on the trunk and extremities. In most infants, yellow is the only finding on physical examination. More intense jaundice may be associated with drowsiness. And there could also be other neurological findings, such as changes in muscle tone, seizures, also the related cry, the characteristic of the cry in a significantly jaundiced baby. So investigation, we can do the transcutaneous bilirubinometry. We can also check the bilirubin, total serum bilirubin levels. So additional investigations may be indicated if the baby presents with jaundice on the first and or third day of life. Baby is anemic at birth. It appears ill, has serum bilirubin levels which are high enough to trigger treatment. If the jaundice is significant and persists beyond the first 2 weeks of life, and if there is family, maternal, pregnancy history, suggestive of pathologic processes, then we can even do the additional investigations, which are, we can check the blood type of the mom, RH determination in mother and infant. We can do the direct antiglobulin test in the infant. That is the direct Coombs test. We can check hemoglobin and hematocrit values. We can also check the serum albumin levels. And then we have detailed investigations of neonatal jaundice, as in when to do, when on early onset, after 24 hours, or prolonged neonatal jaundice. I'm just going to do just a summary. So for the early onset neonatal jaundice, we can do the hemolysis workup, mom blood group and Coombs. We can do FBC, differentials and smear, reticulocyte count. We can do TSB, and we can start intensive phototherapy and repeat bloods in 4 hours. And then neonatal jaundice, after 24 hours, we have to first exclude hemolysis. We must rule out all the infections, and also the baby must also, the mom must stop breastfeeding the baby unless the exchange transfusion is planned. On prolonged neonatal jaundice, which is more than 10 days in term babies and more than 21 days in preterm, TPN is given. We must examine for hepatosplenomegaly, stools. We must do FBC, retic, stiffs, smear, full LFTs, TFTs, alpha-1 antitrypsin levels. Yeah, so that's the graph summarizing that's the detailed investigations. Now moving on to the management of the neonatal jaundice. So the most important thing, the aim is to prevent the kernicterus. So we must do the daily examination to detect jaundice early. We must investigate according to causes, and we must check the formal total serum bilirubin, fluids and feeds. And also we must remember the phenobarbital, which enhances the uptake, hepatic uptake, and conjugation and excretion. The dose is 5 milligrams per kg IV or stat. So those are we also have photos there of the management, the phototherapy. So yeah, as I said, it's also important to make sure that we do the correct maintenance of fluids. If the neonatal jaundice is severe, we must encourage the NGT feeds and or feeds under the light to maximize phototherapy exposure, and also limit time for breastfeeding. So if the baby is being on phototherapy, we must make sure that we limit the time for breastfeeding so that we maximize the time for phototherapy and also encourage the NJ to feed, but the baby must be fed. And we've got the graph there, which helps in the management. So we've got the phototherapy graph and the exchange transfusion graph. So how it works, you check the weight of the baby and also you check the age of the baby. I'm going to say the age because, you know, like the hours there, they determine the age. And then you check where the levels of TSB, how much you got, and then you try, for example, let's say, because the baby weighs, let's say the baby weighs 2.3 and is let's say it weighs 2.3 and is 3 days old. So 3 days is 72 hours, right? So you just match 72 hours and then you check the weight of the baby, 2.3, which means it's the line from the bottom, the 1, 2, 3, 4, 5. Yeah, so it's in that line of the 34 to the 34 weeks, 6 days, or 2,000 to 2.499 grams. So that's how you do the, that's how you check. You must have the age of the baby or the hours of the baby, and also you must have the level of the TSB, and also the weight of the baby, so that you can be able to check which line. If the levels are below the line of the baby, the one that you'll be checking, then there's no need for phototherapy. But then if they're above, then phototherapy is indicated. Same applies for the exchange transfusion graph. So the bilirubin encephalopathy, which is one of the complications of neonatal jaundice. The high free bilirubin levels alter the membrane function, and the bilirubin crosses the blood-brain barrier, which is the area with high blood flow and high metabolic rates. And then it results in toxicity. So the connectors is the yellow staining of the basal ganglia and hippocampus, and that's the autopsy diagnosis. So you can only see it when you're doing the autopsy. And then asphyxia, sepsis, acidosis, hypoglycemia, and respiratory distress syndrome. They also predispose to connectors. Clinical features, it's going to be poor feeding, it's going to be irritability, temperature instability, cycling movements. Those are the early signs. And then it will progress to opistotonus, and then crossed extension of legs, high-pitched cries, setting sun eyes, and then we've got the terminal features, which are gastric and pulmonary hemorrhage. And then I've got the pictures there of the opistotonic posturing and the setting of the sunset eyes. And the long-term complication, hypotonia and developmental delay, chorioathetosis, intellectual impairment, high tone deafness, dental dysplasia, spastic cerebral palsy, clumsiness, and death. And then I've got a summarized, some graph there that is sort of summary of the neonatal jaundice. That's a nice summary to look at, and then it helps. Thank you so much, guys. That's it. And thank you so much for checking and viewing our talk today. From me, Dr. Mngeni, bye.